Hey everyone, glad to have you back here for the second half of the Introduction to Neuromuscular Medicine lectures. As promised, we're going to be focusing on Guillain-Barré as well as a few other neuromuscular emergencies in this one. So let's get started. So before knowing how to treat Guillain-Barré, you had to be able to recognize the disease. So luckily, Guillain-Barré has a fairly classic history that's actually drilled into the heads of a lot of medical students. If anything, just because it's so unique. So typically, the disease has a subacute course of progressive lower extremity weakness and sensory loss, typically ascending in nature. And then this often follows a recent URI or GI infection. That said, there are a couple of less commonly tested components of Guillain-Barré that you should be aware of. For one, the disease frequently manifests with significant pain as a result of the inflammatory demyelinating process. For whatever reason, this component of the disease is often overlooked, and so it's actually not uncommon for Guillain-Barré patients who have low back pain and lower extremity weakness to be worked up initially for a bunch of spine pathology. So just always keep Guillain-Barré in the back of your mind when you hear about back pain and then bad nerve pain. And then also, while it's more complicated, just know that while there is a classic Guillain-Barré variant, there are a lot of other variants that exist as well. The most common of which you might hear about is something called Miller-Fisher variant, where the patients have a triad of ophthalmoplegia, ataxia, and sensory loss. So given that Guillain-Barré can present in different ways, the exam is really the most important here. So for one, they should be experiencing a weakness that is symmetric. So asymmetric weakness is very unlikely to be Guillain-Barré. Then, of course, they can have sensory changes as well, but it's actually not always present. And then finally, they must have areflexia of the affected limbs. So you really have to hammer away at those reflexes because intact reflexes, especially in the lower extremity, are going to drastically decrease the chance of a patient having Guillain-Barré. If you can't clinch the diagnosis of Guillain-Barré with history and exam, there are actually some ancillary tests that you can perform to support your diagnosis. So this includes a lumbar puncture that will demonstrate the classic albuminocytologic dissociation, which in less fancy words just means elevated protein and normal white count, as well as an EMG, which will show evidence of demyelination and something called a prolonged F wave. That said, it's important to know that these findings don't typically arise till about 10 days or so after symptom onset. LP and EMG can definitely help differentiate typical courses or difficult courses, but it really shouldn't be relied upon early in the disease. Remember, Guillain-Barré is a clinical diagnosis, so if you believe a patient has it, you definitely shouldn't delay their treatment just to get these tests. And also, if you really believe they have it and these tests are negative early in the course, you still should be treating it. Just kind of a fun fact aside, you can see here, FDR was diagnosed with polio, but if you go back and read about it, kind of the expert consensus is that he probably had Guillain-Barré, which is interesting. So with that in mind, let's talk about treatment of Guillain-Barré. So similar to myasthenia, our mainstay of therapy here is either IVIG or plasma exchange. And then also like in myasthenia, both have been found to be pretty efficacious. So as you can see here, same thing as myasthenia, usually a 5-day course of IVIG or a 7 to 10-day course of Plex. On the other hand, while steroids sometimes play a role in myasthenia, they never play a role in Guillain-Barré. So not only have they been shown to be ineffective, but they also may potentially worsen chance for recovery. So please avoid them and just stick with IVIG and Plex. There has been some potential benefit shown from some novel monoclonal antibody therapy, but this is all experimental at this point. In all, Guillain-Barré is generally a reversible disease, but that said, getting the patients through to the recovery period, there's a lot of things that can go wrong, a lot of things that can cause people to die in Guillain-Barré. So supportive care is really important. But let's talk about some of those things that kill you in Guillain-Barré. So like in myasthenia, Guillain-Barré syndrome can affect the diaphragm and other respiratory muscles, leading to respiratory failure. So neuromuscular parameters and monitoring with things like FECs and NIFs should be performed throughout the hospitalization, just like we would in a myasthenic patient. But actually, probably more dangerous than the respiratory failure in these patients is the potential autonomic dysfunction that's seen in about 70% of Guillain-Barré patients. So demyelination of the autonomic fibers can cause severe arrhythmias, things like SVT, aflutter. You can see a picture here of a complete heart block and prolonged asystole. And so telemonitoring is really necessary in a patient with Guillain-Barré. And then beyond this, their autonomic dysfunction can also cause them to have very difficult to control blood pressure. So they can swing really high, ranging from paroxysmally high to severely low. And so for this reason, these patients often end up in the ICU where we can use a really short-acting agent, so things like esmolol or neosynephrine to quickly bring them down. And that's a lot of very sad stuff. So let's look at Willow, see how happy she is. Take a quick breather, and then we'll go back into talking about really sad things. Specifically ALS, which is probably the saddest disease in medicine. So I'm just going to briefly talk about ALS here. It's a very important neuromuscular disease to talk about, and it deserves a lot more attention than I'm going to give it. I'm blazing it over it here just because it doesn't really fit into this lecture of neuromuscular emergency. As you know, it's a disease characterized by upper and lower motor neuron pathology. It's typically fatal in about 3 to 5 years, often from respiratory failure or aspiration. But the big takeaway, and again why it's not in this lecture as much, the big takeaway is that ALS follows a gradual and a steady clinical course. So I bring this up solely to emphasize that patients with ALS should not decompensate quickly solely from their ALS. If an ALS patient is rapidly declining, you always need to look for underlying issues causing the decline, especially ones that are often reversible, such as pneumonia. Assuming that a patient is dying from their ALS when they were walking around the house with only mild weakness the week prior would be incorrect and could be a fatal oversight. So please try to remember this. And then last thing I want to touch base on in this lecture is other comorbid conditions that can arise within the neuromuscular disease that aren't a direct effect of muscle weakness but do cause significant morbidity. As I already talked about, you've got to keep in mind significant arrhythmias and autonomic failure in Guillain Barre. And again, just always remember to keep those patients on tele. Beyond this, though, restrictive lung disease is commonly seen with neuromuscular patients, including both structural restriction as a result of chest wall weakness and scoliosis, but then also actually intrinsic lung disease such as interstitial fibrosis. So specifically, polymyositis and dermatomyositis have really high rates of interstitial fibrosis, and so it's important to screen these patients for such by using intermittent chest CTs. And then finally, cardiomyopathy is commonly associated with a lot of these diseases, primarily the muscular dystrophies. So dystrophies such as Duchenne's or Becker's can often manifest either as a hypertrophic diastolic heart failure or a dilated systolic heart failure. And then also all these patients, given all their restrictive lung diseases, are also at risk for cor pulmonale. So keep an eye out for that. And that's all for this lecture. So again, neuromuscular medicine is typically an outpatient specialty, but you're really going to run into some of these patients inpatient. And as I said, they can get very sick very quickly. So it's important to know it. So let's do a couple review questions to drive home those key points. Okay, first question. So 68-year-old male, past medical history of myasthenia gravis, presents with increasing weakness. Which of the following findings on physical exam would be most likely to push you towards urgent intubation? Would it be A, significant bilateral ptosis, B, breath count of 40, C, an inability to walk, D, 2 out of 5 strength in his neck flexors, or E, facial droop? The answer here is D, significant weakness in the neck flexors. And so remember that neck flexion and extension is a really good outward sign of bulbar dysfunction, and weakness here can be an imminent sign of respiratory failure in myasthenia. Significant ptosis and an inability to walk are definitely associated with severe myasthenic exacerbation, but they don't always correlate with respiratory distress. And then a breath count of 40 isn't quite normal, but it actually isn't that poor. Speaking of breath count, though, here we have a 42-year-old female with a history of myasthenia who's admitted to the hospital. A breath count at what level would warrant elective intubation? So 50, 30, 20, 10, or 5. And answer here is C, 20. So as you can see, a general rule of thumb is that a breath count of 50 or greater is normal. 30 is concerning and should warrant transfer to step down. 20 should prompt elective intubation, and then 10 will require emergent intubation. Okay, for the next question then, the same patient is admitted to the hospital. And so you intelligently go to order neuromuscular parameters on her, but you realize that the order set is gone and you're going to have to wing it. So which of the following should you ask the respiratory therapist to obtain? A, NIF and FEC, B, NIFs and TLC, C, TLC and FEC, D, an FEV1 to FEC ratio, or E, an FEC and TLC. And here it's going to be A. Neuromuscular parameters include a NIF and FEC. And then remember, just try to remember those cutoffs. We worry about NIFs below -25 or -20, and then FECs below 1.5 or 2, which is 15 cc's per kilo. Okay, next question. At what time does a joke become a dad joke? When the punchline becomes apparent. Get it? Apparent. Okay. 34-year-old male with a history of anxiety presents with 3 to 4 days of ascending symmetric lower extremity weakness and back pain. He notes that 3 weeks ago he was traveling abroad when he developed bloody diarrhea. On exam, he had significantly lower extremity weakness and areflexia in both his Achilles and patellas. What is your next best step in management? Should you A, obtain a lumbar puncture prior to initiating IVIG, B, obtain EMG prior to initiating Plex, C, obtain lumbar puncture prior to initiating post-steroids, D, administer post-steroids, or E, administer IVIG? And your answer here is E, administer IVIG. Remember, Guillain Barre is a clinical diagnosis, and in a case like this where you have a textbook history and exam, you really shouldn't be delaying care with additional testing. Instead, should immediately start appropriate treatment. If you need, you can always get the LP or EMG later, but it's best to just get this person an IVIG and Plex right now. And then finally, don't forget that steroids are an answer choice here, but they should never be given in the treatment of Guillain Barre. IVIG and Plex are used instead. Okay, last question. 74-year-old male with a past medical history of diabetes, HFrEF, colon cancer, and quote-unquote some sort of muscle disease, which you can't remember, presents with weeks of progressive dyspnea. A CT chest performed demonstrates advanced interstitial fibrosis. This pathology is associated with which of the following neuromuscular diseases? Is it Duchenne's muscular dystrophy, Becker's muscular dystrophy, dermatomyositis, Guillain-Barré, or myasthenia? That would be C, dermatomyositis. So remember, the dystrophies are associated with cardiomyopathy, Guillain-Barré is associated with arrhythmia and autonomic failure, and the myasthenia is associated with thymomas. And it's just really important to remember a lot of these associations. Other than thymoma, although we will take those out because it helps these patients, the rest of these are often the ways that these patients die from their disease, and so it's really important components of the disease to remember. That's it. Neuromuscular disease is very complicated, but if you understand just a couple of the key concepts we talked about here, you should be able to tackle a majority of these syndromes that you're going to see in patient. So thanks for listening, and I'll see you on the next lecture of Neurology for the Non-Neurologist.